We are here talking on what may be a little bit of a controversial topic. I got a lot of response when I talked about this on stories. A lot of people were like, wait, what? So yeah, we're going to talk about thyroid medication today and the mainstream conventional thyroid medication approach, and why it is probably actually making things worse, and why the majority of people that come to us feeling awful that are on thyroid medication that's supposed to be helping them feel better, why it's not working. So we're going to dive into the science of it today. We're going to dive into kind of the awful side of the drug world and what they ultimately are aiming to do. And yeah, it's going to be a good one, I think.
It is. And I think that, as you listen to this, you might get a little fired up, you might get a little angry. I know when we heard at the conference we were at in Salt Lake City, the discussion around Synthroid and how basically the research showed it's the worst thyroid medication and they just buried it. The pharmaceutical companies buried it. The researcher, the head clinician, went on to 60 Minutes and talked about this. And they basically got fined $1 billion, which in their industry is like chump change. So the research was found that Synthroid is the worst, and whatever the parameters were there, and it is one of the top prescribed medications. But Synthroid and levothyroxine, both T3, T4 medications without T3.
Yeah.
Call them one and the same. So that's what we're going to talk about today. And just really, really high level here. We've done multiple podcasts on, the thyroid being kind of the canary in the cave. Is it really the thyroid, or are there other issues at play? And you can go back and listen to those episodes. But we're just going to break down very quickly how your thyroid works. And I think this is important because a lot of people also do not understand that TSH is not a thyroid hormone. It's a thyroid stimulating hormone. And that's very different from looking at your T4 and T3, which is your inactive and active thyroid hormones. So you have the hypothalamus, which is in your brain. This is where it's like your stress command center, as we kind of say. And this is communicating to the pituitary through something called TRH. And this is thyroid releasing hormone, I believe, right? And the pituitary is then giving the TSH, thyroid stimulating hormone, to the thyroid glands. And then that's going to turn it into thyroxine, which is your T4, and then your triiodithyronine, T3. It's a long word.
Yes.
Doesn't matter. T4 is your prohormone, inactive. It's got to get converted in the liver, the gut, the muscles. And then T3 is the active thyroid hormone. That is going to be your gas pedal. So if you want to lose weight, you want to have good energy, you don't want your hair to fall out, you want to have mental clarity and not have brain fog, you want to feel warm or have normal regular temperature in your body, not feeling cold all the time, T3 is really what we want to look at. And when we look at these levels, a free T3, many people will argue what the ranges are. But I think you have to remember that it really is person independent as to what they feel good with. I've heard everything from 3.0 to 4.3 being an optimal functional range, depending upon who you're hearing it from and what their, supporting evidence is. But at the end of the day, I have also seen individuals with a free T3 at a 4.1 say, I feel anxious, right? I feel more jittery, overstimulated, right? And then they're maybe feeling these hyperthyroid symptoms because they're over medicated with T3. So I think the sweet spot is always going to be within that range somewhere, how you feel. But what we do know is that from a motility perspective and a weight loss perspective, about 3.5 is really a good sweet spot. 3.3 to 3.5 is where you're going to see someone feel better with their bowel movements. They're not struggling to go to the bathroom as much as they were previously. Maybe your TSH is fine, but your free T3 is only at a 2.1. I bet you're very constipated. I bet you're tired. I bet you're struggling to lose weight. I bet you want to fall asleep at 3 o'clock and can't think, right? Like free T3 is really the main one that I think is really, really important to look at on blood work. And sadly, it is not part of the standard, air quote here, standard thyroid hormone panels. So you have to advocate for yourself to your doctors. And we'll talk a little bit more about that when we get into the medications as well. But if you are only getting a TSH and a T4, and they're air quote normal ranges, you also want to make sure that you are looking further to say, okay, if this is true, but I still have all these symptoms, then what's my free T3 and my reverse T3? Because you could be dumping and just not utilizing. Your body's trying to convert it, but you're not getting the active form and you're dumping it off. And that's, the problem that is also often overlooked. So you just remember you have to advocate for yourself.
Yeah. So essentially, TSH is not an active hormone. T4 is not an active hormone at the cell level. T3, the free T3 is the active hormone at the cell level. So if we're really looking at thyroid health, thyroid function, we have to look at T3. And doctors will argue that it is not a helpful test. It is absolutely a helpful test. It's a necessary test, in my opinion. And we're going to talk about in just a minute why it gets overlooked and why it becomes the problem and why your labs look normal and you still have all the hypothyroid symptoms. So in this whole negative feedback loop, Liz kind of talked about the TSH gets sent to the thyroid, the T4 and T3 get produced, it gets converted, and then the brain kind of reads the room and says like, okay, is there enough T3 there? Should I upregulate or should I downregulate TSH function or TSH release? Also, how much stress, how much inflammation, how healthy the gut is, the liver is, can all affect this negative feedback loop. And when we look at dysfunction, there's like 4 to 5 different dysfunctions of the thyroid. Number one is autoimmune. The majority of hypothyroidism is autoimmune based. And again, in these cases, the thyroid's not really the problem or like the source of the problem. It's more the victim of the attack. Not saying that thyroid medication couldn't be potentially helpful in this situation, but you need to address the autoimmunity piece. You need to address why the immune system is kind of essentially attacking the body to an extent. Some people are more predisposed to hypothyroidism and Hashimoto's autoimmunity. Other people, it's a different autoimmunity. Other people don't have autoimmunity predisposition. So it is very case dependent, but autoimmune is the most common. Thyroid resistance. So this is usually an inflammatory or insulin resistance problem. Again, not a thyroid problem, more of an inflammation problem. But also as you age, the cells don't hear as well. So sometimes you do need higher levels of hormone to be able to support the symptom relief that people are trying to get. But essentially, in these cases, there is a message there. There is adequate hormones there, but it's not being heard. The cells can't hear it. So again, that's a big one. We're going to come back to that. Elevated thyroid binding globulin issues. So this is often seen with high estrogen and during perimenopause is very common. It basically binds up to your hormone, makes it unavailable to use. Secondary hypothyroidism due to pituitary dysfunction. This is usually a stress-based issue. This is not a thyroid issue. This is a signaling issue. The brain, the hypothalamus is sending too strong of a signal to create hormone, even though levels seem okay. This is, again, a stress issue, not a thyroid issue. And then poor conversion. We talked about that. T4 doesn't convert to T3. So where do these medications come in, right? The most common medication prescribed, Synthroid, aka levothyroxine, or Levoxyl is another name for it. But this is a synthetic T4 medication. And the frustrating thing is that the medication is prescribed regardless of what the dysfunction is. Whether it is autoimmunity, whether it is a gut-based conversion issue, whether it is an inflammatory or insulin resistance issue, they prescribe the same medication. And so this is obviously something we have a big problem with because T4 isn't the issue. The conversion to T3 typically is the issue. The autoimmunity and immunological function is the issue. The stress, the inflammation, the hormone imbalances, the poor HPA axis, those are the issues. Yet in the medical world, all we care about and all that they are told to care about is the TSH level. And adding T4 in most situations will lower that TSH level because, again, the brain's like, oh, we got T4 here. We don't need any more T4, so it's going to lower TSH signaling. And so the doctor sees, oh, TSH is normal, T4 is normal. It's not a thyroid problem anymore. Your constipation, your fatigue, you're feeling cold all the time, you're thinning nails and hair. It's not a thyroid issue because your TSH level and your T4 level are normal. Not so fast. One, we are here to optimize. We are not here to just treat the insufficiency. We're not here to just get you above water. We're here to have you float above the water. We're here to have you feel amazing like you're walking on water, okay? And so what doctors will do is they basically will treat until it is no longer hypothyroid. So they're going to treat until that TSH comes into a normal range, and then they hold. They will not change medication dose. They will not change medication type. And sometimes they might even pull you off of the medication if your TSH gets too low because now it is no longer covered under insurance. And so this is the really evil part of the drug world and the medical world and how they are all in bed together is they really only cover when it is clinically necessary, not when it is symptom necessary, not when it is quality of life necessary, only in their rules and their red tape. They allow.
Yeah, and I think what's really frustrating too is that, research we know takes 16 to 20 years to make it to your doctor's office. And one of the things that we also talked about at the conference is that the AMA, right, or all of these different boards and associations that are looking at how we treat thyroid disease are just now starting to recognize that, oh, if we put T4 in place, that downregulates natural production of T3, and there's all these different enzymes that are involved, and there's side effects here and consequences but it's kind of almost being ignored because they don't know how to address it. Just kind of like we talked about endocrine disruptors, and they know it's a really big issue, but they don't necessarily know how to address it. There's not a pill for it. So we're just going to kind of ignore it. And it's very frustrating. So I have seen so many people, I know Becca has as well, who come in, they're on thyroid medication. Sometimes they're on like what I would just say is a placebo dose, where it's so tiny dose that you're like, okay, is this even like doing anything for you? And they're like, no, I haven't noticed a difference. Or the person is getting increased, in their thyroid medication. And they're also saying, no, I don't really notice a difference. And so many people, even listening to this podcast right now, maybe you're on Synthroid or levothyroxine or another T4 only medication, and you're still struggling with symptoms, but your labs all look normal. So they're not changing anything. And that's really where we, as Becca was saying, want to help you kind of optimize. So let's look at symptom management. And then also, if you are somebody who can get on a more natural desiccated thyroid medication, let's say NP Thyroid or Nature Throid or other ones out there, maybe it's a compounded medication that you're getting, and you still don't notice a big difference, then you have to look elsewhere and figure out, okay, what else is going on here? Is there infections driving inflammation? Like, why can't my cells hear things? Do I need to really go through some, other deeper healing work in order for me to utilize the medication or hormone or X, Y, or Z, whatever it is that you're feeling, and look deeper. So that's just a kind of a note there, because I think that so many people aren't thinking about all the pieces of the puzzle that come to play. And a lot of this is also going to be food related too. If you are, only consuming what you always have, and you're not looking at how food makes me feel, you're not realizing that, hey, I have Hashimoto's. Maybe I shouldn't be continuing to eat gluten and grains for this period of time while I work on the underlying foundation, because those mimic things at the cellular level, right? So I think it's just always about having this conversation to educate you, but still want to put that caveat here that you need to look further if you are doing everything else, according to your doctors at least, and things still aren't improving.
Yeah, absolutely. And let's talk about kind of what is subclinical versus what is hypothyroid too. Because like when a doctor is looking at labs, they are looking for a TSH level above a 4 to a 5. Like different labs, different doctors will kind of qualify something different, but they are basing it off of a TSH level in most cases. So we're talking 5 to 10. An optimal TSH level is below a 1.5. And so you are way far gone when your TSH is reaching the 4s, the 5s. And when you are in this place, you feel cold, you feel tired, you feel fatigued, you feel like your brain is just in this cloud like of smoke. You can't think straight. Thin hair, thin skin, thin nails, weight gain, increase in body fat. Constipation is a huge one that I think gets overlooked for a lot of people that struggle with chronic constipation. A lot of people don't even think to look at their thyroid. Major impact to migrating motor complex and the vagus nerve health. Menstrual irregularities is also really common with thyroid deficiencies. And so the hard thing is women are often dealing with thyroid deficiency, but they aren't clinically hypothyroid. So what we mean by that is hypothyroid is low levels of thyroid and high TSH. Deficiencies, you have symptoms of the thyroid being suboptimal, but you don't have TSH levels elevated. You might have low T3, who knows, because they're probably not looking at it, but you do not have that TSH indicating that there is something clinically wrong. And so you're told it's normal. We love that phrase. Everything's normal, right? So we already kind of went over why this happens. The autoimmune, the poor conversion, the inflammation, the insulin resistance, all of those things. But something else to understand is one, as you age, we lose robust levels of hormones. You just do. We see this in research. Children, teenagers, young adults have much higher free T3 levels and much healthier TSH levels if you were to test them, in most cases. We're talking like free T3 levels a lot of times in the 5s, the 6s, sometimes even the 7s. And as you age, in any sex hormone, steroid hormone, and thyroid hormone, we just see levels of hormones decline over time. Number two, your cells become less sensitive to your hormones. They just do. Like, there is an accumulation effect, you guys. We wake up every day. It is not the same health the day before. Like, there is this slow creep of the body declining because of environmental exposures, because of chronic stress, because of poor lifestyle and diet, because of unhealthy relationships, whatever it might be. But like in general, your cells just become a little bit more inflamed all the time if you're not really on top of things. And the environmental exposures is huge. We just deal with more things than we used to. And in turn, I think we may need slightly higher hormone levels than what we used to need to be able to feel the same from them. Because again, your cells don't hear them the same. There's more clutter there. There's more noise. There's more static. you might need higher noises from the hormones, higher levels. And again, all of these scenarios end up with this hypothyroid related symptom, but normal TSH, except just a primary hypothyroidism. And that might be treated. Many doctors even say that testing beyond that TSH is just useless. Like, they don't find it helpful, which I think is straight up bullshit. I think you should be able to have what you want covered under insurance. It's just not the world we live in. It isn't. And so if you want answers, you're probably going to have to go the functional route or the holistic route, because those are the people. And unfortunately, a lot of times outside of insurance, outside of HSA, by the way, HSA accounts are great in terms of taxes. I learned that this morning. Tax deductible, no income, no tax added when you take it out of it. You actually get like all kinds of benefits. It's a triple benefit account. So for anyone that is considering an HSA. Fun fact, I learned that this morning. But you essentially may need to go out of pocket to get the answers that you need and the care that you need, which is just unfortunate, but it's the reality. So Liz was saying too, guidelines, they take a while to get to your doctor's table. Anything up and coming in the research, your doctor might not see for 15 to 20 years.
Yeah.
Same.
It's crazy. And we're talking about endocrinologists, right? That's their sole job. And the American Academy of Endocrinology, this is 20 years behind. Like, why? I guess I'm wondering why that's acceptable. I don't really see how it can be acceptable. I know that research takes time and, there's a lot of things that need to go into a research study, but 20 years is a bit extreme. A year or two, maybe I could see that, but 20 years. So what am I supposed to do in the next 20 years? Just feel like death? Maybe be near death? Maybe die? Right? I mean, some of this stuff is really serious because this impacts your quality of life. Right. And so this is just something I can tell you guys the price out of pocket through just LabCorp that we pay is $48. You want a whole thyroid panel, you want your antibodies checked, TPO, TPG antibodies, $48 is what we pay. Right. So let's walk through a little bit about, why they're only using these T4 medications, why T3 is important, and understanding maybe some of the things that you can do or say to your doctors to be able to help make a case to get you over onto a T4, T3 combination medicine. So again, T4, Synthroid, levothyroxine, or Levoxyl, these all contain no T3. It's just T4, and that lowers your T3. So now it's not even helping, but it's hindering. That's not a good thing. How does it do that? It does it by two mechanisms. It shuts down your thyroid, the natural production of T3 from your thyroid glands, as I mentioned earlier, and then it inactivates an enzyme known as deiodinase. So that is supposed to be there to help you get T4 converted to T3, and that's shutting down or being inactivated. It's not a good scenario here, right? And so when you take the T4 medication, again, Becca was saying here earlier, I've got plenty. So therefore your thyroid stimulating hormone, the pituitary is not going to call for more thyroid hormone because it already has a lot of T4. And by the way, when you're taking these T4 medications, it's like a 20 time input to the body that would be naturally dripped to you throughout the day. And so the body again says, whoa, we don't need to make more of this. We have way too much. And so it will start to become almost like immune to it, just kind of ignores it, which is why for some individuals, they also see that over the years that they've been on these medications, it becomes less and less effective. And so your dose goes higher and higher. So that's all happening in the background. And then your thyroid is just slowing down, making both T4 and a little bit of T3 that it usually produces. Because again, you've got this foreign medication coming in and overriding things. No wonder your TSH is going to be lower. That is a kind of a given that the TSH will go very, very low when you're taking higher levels of thyroid hormone. Then we look at the problem with the T4 only medication. So we slow down this enzymatic function. Right? The body is saying, nope, we have enough here. And so as a result, less T4 gets converted into that active T3. So you have less production, you inactivate the enzymes, and then now you have less conversion. And so again, you're still feeling tired, moody, cold, foggy, even though your labs say your T4 is normal. No shit, you're taking a T4 medication, right? And so the bottom line here is that thyroid medication, just like we say with birth control, right? You're overriding your hormones. It's shutting down the natural production. You aren't going to look like you have good hormone levels when you're taking a birth control. You aren't going to look like you have great free T3, total T3, reverse T3 when you're taking a T4 only medication. So when we get into what we really want, some people, they do need the medication. Absolutely. Some people look at, like for me, when I was dealing with Hashimoto's, the positive antibodies, but my Hormones were okay. I wouldn't say they were optimal at that time. Medication wasn't the answer. It was fix the underlying root cause, calm down the immune system, and be able to get those antibodies and the attack on the thyroid reversed. That requires first identifying what the trigger was, what the infections were, and clearing those things out. And then the body can come back to homeostasis. And I think, again, many people just want that quick fix. They're not looking at the whole picture and all 11 systems of your body together. And not to say that's your fault. We look at a conventional medicine, they work all in silos and nobody talks to each other. Your dermatologist doesn't talk to your GP, who doesn't talk to your OBGYN, who doesn't talk to your endocrinologist. Like you have to basically be remembering anything and everything about your health. And also, by the way, try to be a health expert when you're going into these offices, but yet you get the white coat syndrome because these people are maybe not partnering with you, right? They're not speaking to you in a way that makes you feel heard or cared for. And so you freeze up, you tense up. Becca and I both have said this before. Even though we have all of this knowledge and information, I make notes on my phone. Before I go into the doctor, if I'm advocating for myself for something, I have notes, I have research articles, I have books, I have links, I have whatever I feel that I need to back up my case to request this, prescription or a change. So I think that is also something, just to keep in mind as you're like, okay, cool. I want to get on MP thyroid. I want to get on Armor thyroid. I want to get T3 paired with my T4 medication. You've got to have some evidence to come in and back it up. And as we round out the podcast in a few minutes after Becca talks about some other stuff, I will literally read for you word for word what I have some of my clients write to their doctors, and I'm happy to have you use it. But please just also remember, I'm not your practitioner or provider, and this is not medical advice. These are just tips that you guys could use if you want to go and get the T3 with the T.
Yeah. And Liz mentioned earlier that Synthroid research showed there was this, not great outcomes indications of the medication. But understand there is a lot of money that often goes into development of medications, lots of grants, lots of research money. And so if the people running that study can't show that this is optimal or the great answer, they might bury it. Because there's a lot of pressure on those researchers, on those scientists to give the outcome that the people spending the money on the research have wanted to get. And unfortunately, it's the world we live in. Money runs things. And so that is why we have these T4 medications. And because they saw it drops TSH, it technically improves what is the indication for hypothyroidism. Because when you take the T4, the TSH goes down. And so you're like, oh, cool. Things are fixed. But T4 is not the active thyroid hormone. TSH is not the active thyroid hormone. T3 is. You end up with normal TSH, but you're still cold, you're depressed, you're gaining weight, tired, all the things. And we need to get a bigger picture. And the biggest thing that we want you to hear after all of this, because you're like, well, what do I do? You need to address the foundations before you address any of this. Because if I'm considering someone needs to go on a thyroid medication or a hormone replacement or whatever it might be, guess what? I need to get them in the best optimal state prior to doing that or alongside doing that so that they don't need a super high dose. They don't need to just slam themselves over the table with however much is necessary for their body to hear it. If we can improve metabolic health and lower inflammation, optimize gut function, absorption, any lingering gut issues like bloating, constipation, things like that, address autoimmunity if it's present. We need to do those things first, evaluate all levels of their hormones, all symptoms, and then consider the T4, T3, because you may not need medication. You might just need some support physiologically. You might need to learn how to eat better for your body. You might need to figure out how to lower inflammation levels or how to manage chronic infections you've been dealing with or how to rebalance microbiome in the gut. Like, you may not need the medication. Can they be great? Of course they can. And if we do have to go that route, we typically try to go at T4, T3. T3 is a shorter half-life. It has about a 6 to 8 hour half-life. And so you want to take it 2 to 3 times a day. T4 helps back up when T3 kind of runs out. And so you want both of them. Armor is great, but guess what? Synthroid bought Armor to basically bury them because Armor was a great option. Nature Thyroid is an option. MP Thyroid is an option. West Thyroid is an option. And compounded thyroid is an option. So getting it compounded from a compounding pharmacy made specifically for you versus in like a set dosing format. And the reason that we like these is they use porcine, which is pig glandular, and pig thyroid ultimately. And the reason that we use that is because if you look under a microscope, pig thyroid is identical to human thyroid in terms of its cellular structure. And so you are basically replacing exactly what your body needs versus a synthetic form. right? And so those are our options. Some people don't tolerate certain types, and it is sometimes having to like manipulate and do those things. But what I always tell people is if they try taking a T3 and they get anxious, they feel worse, there's other things going on. There's other things, whether it's detoxification abilities, methylation systems, their metabolization rate of things. We need to look deeper. Thyroid may be a need, but I bet that there's other bigger things going on that need to be addressed. So just some things to consider before like, oh, I need a T4, T3. I've been on T4. It hasn't helped. Before you go that rabbit hole, get a full lab panel with us. We'll help you understand, is it the thyroid that really needs to be addressed, or are there much bigger fish to fry before going that route? And then where you can go the route of getting the best option of thyroid medication put in place for you.
Yeah. And I think too, also understanding when you are going to get your labs drawn, you're not taking your thyroid medication the day of. And for some individuals, depending upon their dosing, we might say don't take it for 3 to 5 days prior because we want to see your more natural levels, right? Where is she? Does this actually help? And so I'm just going to read you this. This is something that I put together for a couple of my clients who've recently gotten off of their Synthroid or levothyroxine and onto a T3, T4 combination medication. So here we go. Hi, doctor. Name. I'm reaching out to ask if we could explore a trial of NP thyroid or another form of T4, T3 combination therapy rather than continuing with the T4 only treatment that I'm currently on, levothyroxine. Based upon guidance I've received and what I've learned from thyroid experts, I understand that T4 is an inactive hormone and must be converted to T3, active form that drives energy, metabolism, motility, mood, and more. For many women, especially those with chronic stress, gut dysfunction, or inflammation, this conversion is not efficient, even when the labs are appearing normal. In fact, higher doses of T4 can sometimes suppress natural T3 production and inactivate the deiodinase enzyme needed for conversion, leaving cells starved for active hormone. My current free T3 is, insert your lab range. This particular person was at a 2.1. She's very constipated. And while the lab range is typically 2.3 to 4.4, this was her LabCorp range on the sheet that her doctor drew. So she kind of put in some of these numbers here to make her case, right? I've learned that most women feel the best in the upper half of that range. Many still struggle with symptoms like constipation, fatigue, and difficulty losing weight when free T3 is below a 3.3. She also has all of these issues. So when we wrote this up, we wrote it from this place of what she was struggling with. And then we just round it out and say, of course, I recognize that optimal levels are individual and symptom based, not a one size fits all. I'm aware that T3 has a short half-life, and I'm open to splitting up doses 2 to 3 times a day if needed to maintain stable levels and symptom control. I'm hopeful we can trial the MP thyroid or a compounded alternative if appropriate to see how my body responds to a more complete thyroid support. Thank you for considering this request and for working with me as my partner in care. So we gave the information, we gave a little bit of data to back it up. We made it clear she knows what she's talking about. And then we also respectfully made the request. And thanks for the partnership in the case. Very simple and easy. You don't have to go in with a bat swinging at your doctor and be like, I can't believe you know what I mean? Like, that's not the partnership that you want to have. You do want to just kindly ask them if they're willing to help you in this. But I agree with Becca, get a full thyroid panel. If you're somebody who is, not even on a Synthroid or a levothyroxine medication, but you're listening to this episode because you think something might be going on, do a lab review. Links in the show notes. You can do that with our team with the 1 hour review. We can walk you through that. And if you know somebody who's struggling or has been on medication and they're still struggling, please share this episode with them. Share it on social media. Let people know that, we're here to just bring the truth. This is not medical advice. We are not your practitioners. We're not working with you individually to help manage your care, but we do want you to have the information since apparently our medical boards are 20 years behind. Hopefully we can bring this information to you faster. And the only way that we can continue to do that and grow this show is if you share it. So don't forget to rate, review, subscribe, share the show. And if you want to schedule a call with our team or book in a lab review, links are in the show notes.